Good afternoon, everybody. My name is Waard-van and let me introduce our two guests today. This is Professor Flora de Waard-van der Spek, and this is Professor Arnold Oranje, both pediatric dermatologists, and we will discuss today the new paper, position paper on patch testing for allergic contact dermatitis in pediatric patients, recently published in Pediatric, Allergy and Immunology. So my first question is, what was the demand and what led to the creation of such position paper?
Well, in last years it becomes more and more apparent that allergic contact dermatitis in children appears to be on the increase. And contact sensitization may already begin in very early childhood. Patch testing is the gold standard test for diagnosis of allergic contact dermatitis in adults, but until very recently there were no consensus guidelines for patch testing in children. So some years ago we took the opportunity to in the EAACI give rise to a task force, allergic contact dermatitis in children. And we did find many experts from Europe interested in this topic. And so we worked together on factors that are interesting and important in children, leading to our first paper in 2013, a review article. And then we kept talking on allergic contact dermatitis, on testing, etc., because we found that it's very hard to compare different studies until now in literature, because of differences in methodology, differences in referral patterns, differences in patch test series. And we think that it's important that an international group of experts in cooperation alerts pediatricians, alerts pediatric allergologists, alerts pediatric dermatologists of the frequency of allergic contact dermatitis in children and of doing patch tests in children with, for example, recurrent eczema or therapy-resistant eczema. And that's why we discussed many times with each other about literature, about our own experiences, looking after a patch test series to propose for do it a little bit standardized in the future. And that came eventually to this position paper on a practical patch testing in allergic contact dermatitis in children.
And which are the most common contact allergens in children?
Well, of course, the rate of positive patch tests reflects different exposure patterns at first. And the local selection criteria and the patch tests performed do not be very equal always. But when you read all the papers over the last years, the most common allergen that is found that is nickel still. It was and is, as in adults, indeed. Already in 1994, Professor Oranje wrote an article on allergies in children, and nickel was one of the most important ones. We did also do a retrospective study in which we found nickel as one of the most important allergens. But other important allergens found are, for example, fragrances, for example, rubber chemicals, recently also colorings, and also very nice to mention perhaps is a recently paper by Bellona Fortini and co-workers in which they describe an analysis of patch test results in children in Europe for about 8 years, and they found also a top 10 containing nickel sulfate, colophony, fragrances, chloromethyl isothiazolinone, among some others.
And is the baseline series used in patch testing of children different from the one that you use in adults?
Well, it's good to remember that compared to adults, children are exposed to a different array of components, of course. And next to that, children have limited space available for patch testing. So that's why we were looking after allergens to be tested with and we discussed many times on it. And actually, at last, we proposed a rather limited series as baseline pediatric series, containing about 9 allergens like nickel sulfate, like coliformium, like some rubber chemicals, fragrances. And additionally, we also recommend other allergens which become apparent because of history or because of the examination of the child. For example, when there is a very resistant foot eczema, it's useful to take some allergens being present in shoes like potassium dichromate. Another important thing is that we think it's very good to include also own materials from children that they use into the patch test panel. For example, cosmetic creams bought over the counter or natural remedies. And those are, of course, compounds that are indeed in contact with the skin of the children. So when you then compare that series we propose with the current baseline series for adults, then you will find most of the allergens also mentioned in adults, but tested at once all together. But of course there are some allergens to which the children are not exposed so many times, like for example an allergen as epoxy resin, and we did not add it, of course, in our pediatric series.
Professor Orane, could you please tell me what is the lowest age at which a child could be patch tested?
Well, it's possible from a very young age, even an age of several months, so 3-4 months is possible. But then you do a very selected patch test. You will not do a whole series. And usually, in most cases, we perform patch tests from age 1 year on and at older age, and then you do also selected series. We have a lot of experience because we developed also a patch test for food allergy, and we also performed that from a very early age on. We called it first the SAFT, the skin application food test, and later a direct Atopic patch test. Well, this is actually a test for urticaria, but you can also perform it for a longer time of exposure, and then it's the same as a patch test for other material. So you can do it from a very early age on.
And when are the patch test readings done in children?
Well, actually, it's the same as in adults. There are many differences between children and adults, of course, but reading patch tests, you do it in the same way. So after 2 days, there's the first reading, and then after 2 to 5 days later, you do the second reading. And you should also realize that sometimes you have allergens that give a later reaction. So you have to give an instruction to the parents that you could have a later reaction, and then it's not a sensitization, it's a late reaction. Next to that, there are some substances like sorbitol, for example, formaldehyde and perfumes that easily give quick reactions. So you should also realize that you have to read in some instances an early reading after 20 minutes. Very important.
Okay, and is the International Contact Dermatitis Research Group guideline for reading patch test reactions still valid in children?
Well, I can give you a very quick answer. Yes.
Okay, so I found an interesting acronym in the position paper, which is called Codex. What does Codex mean?
Well, you did find it indeed, because after reading the tests and after finding some positive tests, it is important to take a next step in the procedure, namely to assess the clinical relevance of that test. And that's not also always very easy. And Codex is an acronym for a practical system of assessing the clinical relevance of a positive test. So it may be useful as a tool for interpreting clinical relevance for the positive tests. So I can go over it if you like. So the C stands for current relevance. So the patient has been exposed to the allergen prior to the current disease, the current dermatitis, and improved after cessation of the exposure. Then you can talk about current relevance. The O stands for old or past relevance. So when the patient has been exposed to the allergen prior to the current episode, and there was not an allergen positive, but in a past episode of the dermatitis, there was an exposure of the allergen, so not at this moment, but only in the past, then you can talk about old or past relevance. The A stands for active sensitization, because a patient can be actively sensitized by the test procedure. And then the next is the D, standing for doubtful. Sometimes it's not easy to assess the clinical relevance. Sometimes it's difficult to interpret allergic or irritant reactions, or sometimes there's no traceable relationship between a positive test and the disease, but it's also not really ruled out. So then it's doubtful. Then we have E for exposed, and then there is a history of previous exposure that did not cause a dermatitis. And last but not least, X for cross reaction. Then the positive test is due to a cross reaction with another allergen that is of clinical relevance for the patient. So this acronym may help you as a tool for interpreting positive test results and clinical relevance.
Okay, and according to your experience and the position paper, which are the most common causes for false positive and false negative results in patch testing?
Okay, in the final decision, of course, the patch test reactions must be related to clinical history, to the clinical examination. And a false positive reaction are positive reactions in the absence of contact allergy, mainly related, for example, to misinterpretation of results, for example, using inadequate concentrations of allergens or using irritating vehicles. Or by testing despite current or recent active dermatitis at the test site may also give rise to false positive reactions. And another one is interpreting adhesive tape reactions as positive patch test reactions. And false negative reactions can be defined as patch test reactions not present in the presence of contact allergy. Well, that's of course a little bit difficult sometimes. It may be caused by the use of a too low concentration or of insufficient amount applied, for example. Or there could be present adjuvant factors like insufficient occlusion, like poor adhesion, sweating, friction. Another cause could be that the test site has been pre-treated, for example, by UV radiation or by corticosteroids or by immunomodulators. And these cause decreasing of the immunological response that is important for eliciting the inflammatory reaction necessary for the positive test. failure include late readings, as already mentioned by Professor Orangi. Late readings are important to include. And last but not least, I think it's good to remember that only an allergen that is tested can be recognized. So if you do not test an allergen, then you miss it and you have a missed allergen. So if you have negative test results and you are still thinking that an allergic contact dermatitis is present, then you have to go back to the history, to the clinical examination, and find out if you should test some earlier missed allergens.
Thank you. And may atopic dermatitis, especially if present after the age of 5 years, can be provoked or exacerbated by contact allergy?
Well, that's an interesting point, because if you look after the clinical presentation of atopic dermatitis, then it's completely different in the first 2 years of life. It's not in the flexural areas, for example. And after the age of 2 years, it changes, and it's even more the case after the age of 5 years. While in most cases, eczema is cleared. It clears in 1/3 of the cases after the age of 2 years, and it clears again after the age of 5 years, again in 1/3 of the cases. So I questioned myself for many years why it was still staying there in children after the age of 5 years. And I did, together with Paul Diges, investigations a long time ago in a series of such patients, and we noticed that although in a part of the children there was still food allergy does play a role very early in age and not at that age, but that in many cases, at least in 1/3 of the cases, there was a mixed eczema. So it was not only atopic dermatitis, but it was mixed up with contact allergic eczema. So it's very important in persisting atopic dermatitis to perform in children after the age of 5 years also patch tests to look after possible contact allergies. Very important.
And as one of the key authors of this position paper, what is your message for the future?
My message for the future? Well, we need more studies, of course, and I hope that this group will persist in working together to make a database also to monitor new developments, because the world of contact allergens is changing, because our world is changing, and also the exposure to several substances is changing. And therefore it's important to monitor all the changes and to do future studies, and especially also to look after factors or developments or changes in unselected populations, because it does make sense if you perform such studies in less selective groups.
So thanks indeed for your time, and I am sure that all of you will read this position paper and get acquainted with the details on patch testing in allergic contact dermatitis of children. Thank you.